Well, after this brief review, we've managed to get the patient into remission and into this situation. What do we do now? Do we reduce or withdraw treatment, release the patient, and their doctor take over? So we have 3 options for discontinuing the treatment. We can keep the same dosing frequency but reduce the amount of the drug. We can keep the same amount but space out the treatment, increasing the time between doses. Or do a combination, keep the same schedule but gradually reduce the dose and then maintain the same dose while increasing the interval between doses. Sorry, I mean increasing the number of days between them. What do the guidelines say about this? Well, the latest EULAR guideline recommends for patients in sustained remission, considering gradual dose reduction, not complete discontinuation. And I want to emphasize this is something that can be considered and is far from being a strict recommendation. Mandatory? And also let's remember, only in sustained remission. This level of recommendation is somewhat higher than in the last publication from 2019, and in general the guideline refers to that recommendation. In terms of cost savings and safety from the perspective of patient treatment, they also point out that this is something not included in the drug labels. When you look at the official drug information, it doesn't mention this, at what point, how, or when to do it and how to reduce it. So it's something that is managed in the clinic more or less at the rheumatologist's discretion. Regarding the GRAPPA 2021 guideline, here they do mention patients who are ideally in remission or have low disease activity, unlike with the cellular treatment, which, as we mentioned, required patients to already be in remission. Consider gradual reduction and ultimately discontinuation of therapy. In other words, they also favor a gradual reduction. What are the benefits? Well, there's also mention of a lower risk of adverse effects and reduced costs. But of course, the patient must be informed about the possible drawbacks and the fact that inflammation may occur, which ultimately a pro-inflammatory situation that we are accepting in a patient who at first glance is well controlled, but then when we stop the treatment, we're not sure what might happen and it's an unpredictable situation. To conclude, I bring this observational cohort study, which was conducted with patients with psoriatic arthritis with low disease activity and is part of the Corona registry. These were patients in whom anti-TNF treatment was discontinued and the goal was to evaluate the duration of clinical benefit after stopping this treatment and what characteristics the patients who benefited had from that. From that discontinuation, they started with a group of 325 patients, specifically individuals who were undergoing this particular anti-TNF treatment regimen. The average BMI of this group was calculated to be approximately 30, and an average duration of psoriatic arthritis of approximately about 10 years. And half of them were patients currently on their first anti-TNF treatment, while a third of the patients were on their second anti-TNF treatment, receiving treatment. Half of the patients overall were receiving monotherapy. What happened with these patients? Well, out of all these patients in the group who discontinued treatment, it was observed that nearly 45% ended up during the follow-up losing the clinical benefit of that discontinuation due to various reasons, which are indeed worth discussing in detail and understanding. The majority of them, 32%, required it in clinical practice. Loss of benefit is considered when you have to add a treatment to regain clinical stability. These were patients who had to start methotrexate or required other immunosuppressive treatments. 31% of these patients had experienced an increase in disease activity. Patients who had deteriorated in terms of their skin disease were reported to be around approximately 15%, and nearly 10% of patients needed to start or increase the dose of prednisone. It's remarkable indeed that almost 7%, which I thought might be a higher number, but well, only about 7% of patients restarted or initiated anti-TNF treatment. And what factors did they find among all those patients who didn't do well after stopping the treatment? What factors were associated with that loss of clinical benefit after discontinuing anti-TNF? Well, they found that there was a higher risk of relapse in patients who already had greater disease activity at the time of interruption, which doesn't come as a surprise. And in addition, they were active smokers. It's a bit surprising that overweight and obesity were not associated with a higher risk of relapse, nor was there any association with the number of anti-TNF agents previously used, and neither age nor sex showed any correlation. But being aware of this type of study can help guide us a bit when making decisions. And of course, always support the patient in the decisions that need to be made regarding therapy